Good afternoon.
Good afternoon.
Thank you for joining this webinar. I saw some familiar names. Welcome to the free webinar sponsored by MedExam Expert. And our topic for today will be corticosteroid use in pregnancy. So I am Dr. Adesiri. For my students, you know me already. For those who don't know me, I'm Dr. Adesiri. I'm MRCOG 1 mentor, and I handle microbiology and biostatistics. Okay. So this will be the overview of our topic for today. Okay, corticosteroid use in pregnancy, the key recommendations, the role of corticosteroids in preterm birth and planned cesarean section, those contraindications, risk, and benefits. So our main reference is the Green Top Guideline number 74, which was published in July of 2022. It is entitled Antenatal Corticosteroids to Reduce Neonatal Morbidity and Mortality. This is a 60-page guideline. Okay, so I will be discussing the main points and the summary of this guideline. Of course, you have to read it at least once, okay, especially those who are taking part 2 examination. Okay. And for those taking part 1 examination, this webinar is enough. So this infographic, my students know that I'm fond of infographics, mnemonics, and interaction. So this webinar is not just reading from the slides. So I will be asking you guys questions once in a while, okay? So this is a very, very beautiful infographic that was done by the University of Edinburgh regarding the use of antenatal corticosteroids at term before planned cesarean birth. And this infographic is supported by the Royal College. Everything is written here. Who is it designed for? What is a corticosteroid? When you should give it? How do you give it? Why you have to give it in planned cesarean section? And what are the uncertainties? We will discuss it one by one. Okay? So I have a question. What are the benefits of corticosteroid in preterm labor and birth? So we are all practicing clinicians. Some of us are trainees. So what do you think are the benefits of corticosteroid in preterm labor and birth? Why do we give it to those at risk of preterm labor and birth? Why do we have to give it? Anyone can open their microphone and answer?
Lung maturation.
Okay, for lung maturation. Why do you have to need the lung to be matured? To prevent?
Because to prevent the respiratory distress syndrome.
Very
because
good.
surfactants are not produced properly, produced after 36 weeks. So if preterm, then less surfactant in the preterm baby. So lungs will be collapsed.
So very good. So all of us know that whenever we have a patient who is at risk of preterm labor and birth, we know, and there's no doubt about it, it has been over 3 decades that all clinicians are giving steroids to those pregnant patients who are at risk of preterm labor and birth. Okay, so let's see what the guideline says about it. You see here, it's a quality level of evidence 1++ or A. That means it's a strong recommendation. So we give a course of antenatal corticosteroids within 7 days prior to preterm birth to reduce perinatal and neonatal death and respiratory distress syndrome. So there's no argument about that. For preterm birth, we give it, okay? So what about the benefits of corticosteroid in planned cesarean birth at term? Do we have to give it? This is term and cesarean section. Do we have to give corticosteroids?
To prevent intraventricular hemorrhage, we can also give steroids.
Is it recommended to give it?
Yes, it is recommended.
Yes.
Okay,
Not at term.
Why do you think we have to give it in planned cesarean birth at term? Someone says not, someone says yes, it's recommended. We will see what the guideline says about it. But can you please exercise your brains and analyze why? Why do we have to give steroids in planned cesarean birth at term? What is the difference between a baby who is born vaginally and a baby who is born by cesarean section? Can you make a wild guess? What is the difference?
Because of delivery stress, baby lung get matured more. And cesarean, there is no stress of the delivery.
Very good. So even if this is already term, the baby who is born vaginally is more exposed to the stress of labor. Okay, while the baby who is born by planned cesarean section is not exposed to this labor stress. Okay, so the baby who is born by cesarean has more difficulty of expelling the fluids in the baby's lungs, in his lungs. Okay, compared to those baby that is born vaginally, they are exposed at the stress of labor, so they are more stronger and they have less difficulty in expelling the fluids in the lungs, because if you don't expel these fluids, the air cannot get in. That's why sometimes the baby has difficulty, they become distressed. Okay, so let's see what the guideline says about this. So you can see here that, okay, before we go to that guideline, I would like to ask another question. When do we schedule cesarean section? You are all doing cesarean section. If it is a planned cesarean birth, when do you schedule it?
After 38 weeks.
38.
38 weeks. 38.
Okay.
At
Okay,
least
so-
39 weeks. 38 plus 6 plus.
Okay, so some says 38, some says 39. So in practice, we usually schedule our patients. This is in practice, okay? We usually schedule our patients when they pass 38 weeks of gestation, right? So in between 38 to 39 weeks, okay? But the guideline says, according to NICE, there should be no cesarean section routinely scheduled before 39 weeks of gestation. So they recommend that you schedule your planned cesarean birth as much as possible near to the expected date of delivery, which is 39 weeks of gestation. Okay, because what they say is, for women undergoing cesarean section from 37, the beginning of term, until 38 plus 6 weeks, there should be an informed discussion should take place between the women, okay, because of the potential risks and benefits, of course, of antenatal corticosteroids. So what are these potential risks and benefits? Benefits, you know the benefits, okay? What are the risks? They say if you give the corticosteroids in a late preterm and in early term, okay, the baby will be exposed to neonatal hypoglycemia, okay, and potential developmental delay. So you have to weigh the risk and benefits between this one. And they say if the baby is born after 39 weeks, then this risk is decreased, okay? So this is evidence recommendation category 2B. Okay, so at what gestation should antenatal corticosteroids be discussed and offered? I've already mentioned a while ago. So at what gestation do you give antenatal corticosteroids?
Before 39 weeks.
Usually,
26 or 36 week. Between 26 and 36 week.
26 and 36.
Before
Okay.
34.
Before 34 weeks. So when you say before 34, I can give it a 20 weeks age of gestation. Can I give it
After
a 22?
24 weeks of gestation. After 24 weeks of gestation.
Okay. After 24 and at before
Up to
34 weeks.
39.
34 weeks. Okay. So usually, what I'm saying is usually in practice, we give it 24 to 34 weeks. Okay. For preterm. Okay. For preterm. So let's see what the guideline says about it. Okay. So you can see here, corticosteroid should be offered between 24. This figure is very important. You have to remember this, okay? Between 24 and 34 plus 6 weeks. So we mentioned in the first slide that there's no argument that any pregnant patient who is undergoing or is having a risk of preterm birth should be given a course of antenatal corticosteroids from 24 to 34 plus 6 weeks. Okay? And you can also give it in late preterm birth, okay? Late preterm from 35 to 36 weeks of gestation. Should consider you balance it, the risk and benefits. Okay? That's what I'm saying in the last slide. You balance the risk and benefits. You should involve multidisciplinary team. Okay, but generally, you give it from 24 to 36 weeks. How about before 24 weeks of gestation? Can we give it? Why do we have a cutoff?
No, before 24 we don't give because it's a viability not justified. It considered as a miscarriage before 24.
Okay, before 24 weeks, ideally, it should not be given because you are correct. Even if you give, the fetal survival is very little. Okay, so you don't expect the baby to survive at 22 weeks. But the British Society of Pediatricians, they say that you can offer a course of antenatal corticosteroids even to patients at 22 weeks, from 22 to 24 weeks. So this is a recommendation of the British Society of Pediatricians. Okay, and you can read it in the guideline when you read it in details. But generally, you offer corticosteroids from 24 to 34 plus 6 weeks. Okay. So next question, at what particular instances should antenatal corticosteroids be discussed and offered? So can you think of any maternal condition that we should offer antenatal corticosteroids? Do we offer it to all women?
Preeclampsia, eclampsia.
In GDM.
What else?
History
Diabetes?
of preterm.
Okay, history of preterm birth, preeclampsia, very good. What else?
Twins.
Twins, very good. Okay, so let's discuss it one by one according to the guidelines. First, we go for the twins. Do you offer routinely a course of antenatal corticosteroids to twin or higher gestation pregnancy?
No,
Do you
routinely
offer-
for all twins.
Routinely for twins
For all twin pregnancy.
Okay, why do you think it should be routinely given?
Because they are high risk of preterm birth.
Okay, so we are in that same kind of thinking. Okay, during practice, and we encounter a lot of this. When you encounter a pregnant patient who is carrying twin or triple pregnancy, we know that this twin pregnancy or these women tends to deliver earlier. Okay, but it is not true all the time. There are twins who reach 40 weeks without any complication. There are twins who reach term without any complication. So according to the guideline, corticosteroid should not be routinely offered. So remember, you should be able to differentiate what you do in practice and what you should answer in exam. Please close your microphones. Everyone. Okay, thank you. So you should be able to differentiate. Okay. Dr. Aksa, your microphone. Thank you. So you should be able to differentiate what you do in practice and what is written in the guidelines. That's why we conducted this webinar, so that your confusion will be solved. In the exam, you follow the guidelines, don't follow your practice, okay? So for multiple pregnancy, a course of antenatal corticosteroids should not be routinely offered. So you have to choose who are those at risk of preterm birth and those who are not, okay? So the recommendation for twins is the same as the recommendation for singleton. You don't give antenatal corticosteroid just because they are multiple pregnancy, okay? Okay, and I heard another one says gestational diabetes, okay? Diabetes in pregnancy. What is the effect of a corticosteroid in diabetes, in your sugar level?
Increase the blood sugar level.
Very good. So your corticosteroids increases your blood sugar level. So are you giving corticosteroids for diabetic patients?
No. No,
Are
it's
you
not.
give?
We
No.
give sometimes, yeah, we give in indicated patients and with proper monitoring of sugars and increasing the dose of hypoglycemics.
Very good. So diabetes is not a contraindication to giving your corticosteroids. Let's see what the guideline says about it. Okay, so now we go to diabetes mellitus. Diabetes should not be considered an absolute contraindication to antenatal corticosteroids, okay, especially if you need it for fetal lung maturation. Okay, so you usually, you know that diabetic pregnancy, sometimes we induce it early, okay, because we wanted to avoid sudden infant death syndrome due to diabetes, right? So we don't allow induction of labor, especially at term. We don't allow these patients who are at risk, who are positive for diabetes, to reach their due date. We induce them earlier, okay, because of some risk associated with diabetes. So diabetes should not, even if your corticosteroids elevates your blood sugar level, it is not an absolute contraindication not to give, okay? So if the patient needs it, even if she has diabetes, you should give a course of antenatal corticosteroid. And you have to monitor the blood sugar of the mother. And you have to give additional insulin if needed, okay? For women with diabetes undergoing planned cesarean birth, okay, informed discussion again, the same as singleton delivery without diabetes, okay? So if the corticosteroids elevate the maternal blood sugar, you should advise the patient that a course of antenatal corticosteroid will cause hypoglycemia. So it is associated with increased rates of hypoglycemia, okay?
Excuse
Everything
me, doctor.
is, yes.
Yeah, can I ask one thing?
Yes.
This guideline is telling for women with diabetes mellitus.
Yes.
They want to do for type 1, type 2 diabetes or for GDM also?
Yes.
All diabetes.
For all.
Okay.
Okay. So a while ago, somebody says that we should discuss and offer antenatal corticosteroids for twin pregnancy, patients with diabetes. They said for preeclampsia, fetal growth restriction, and antepartum hemorrhage. So remember, patients with fetal growth restriction at risk of preeclampsia and antepartum hemorrhage, at risk of preterm birth, you should also give, okay? Although a course of corticosteroid, okay, doesn't have an effect on neonate maternal hypertension. But of course, you know, if you need to deliver this patient, you have to go to give a course of antenatal corticosteroid. And the same as patients with diabetes, you have to advise the patient that steroids, aside from causing neonatal hypoglycemia, steroids also causes baby to be small for gestational age, okay? Or the weight of the baby is 80 grams lower than what is expected. There is a difference of 80 grams. Okay, so the corticosteroid decreases the weight of the baby. Okay, but they should be counseled that there is not enough evidence to prove this. Although some says it causes SGA and fetal growth restriction. Okay, but there are limited evidence. Okay, and then also, of course, you know that when a patient goes in, when a patient has a premature rupture of membranes, you know that this patient suddenly goes into labor within 24 hours of rupture of membrane. So the same indication, if they are at increased risk of preterm birth, you should give a course of neonatal corticosteroids. Antenatal corticosteroid, this is level 1, okay? So what is, okay, now I know we have different practice on what dose and route of administration for a course of antenatal corticosteroids. So tell me, how do you do it in your hospitals? How do you give corticosteroids? How many doses? What is the
12
frequency?
MTPD.
Hmm?
We give
12
dexamethasone,
mg BID.
Wait,
12
one by
milligram,
one.
That's a
Dexa, okay.
12
12,
milligram,
okay.
12 milligram.
12 hourly,
Yeah.
2 doses.
Correct.
Q12 times 2 doses. Other one. Anyone else?
Betamethasone,
Mm-hmm. How
12
much?
and 24 hours apart.
Q24. How many doses?
2 doses, doctor.
Times 2 doses. What else? What else?
But recommendations are different.
Dexamethasone,
Yes, Dexa. Yes, doctor. Dexa,
6 milligram,
12 milligram.
6 milligram.
6.
Okay. 6 milligram. 12
For
milligram, how many hours apart?
12 hours.
12
12 hours. Same like the first 2 doses.
milligrams.
Dexamethasone,
Yes.
Dexa has different two doses. Either 12 milligram, 2 doses with interval of 12 hours, or 6 milligram, 4 doses BID.
Q12 hours
4 doses.
times 4 doses times 2 doses. Okay. What else?
It's betamethasone 12 mg intramuscular 2 doses 24 hours, or dexamethasone 6 mg intramuscular 4 doses 12 hours. And if it's to be
How many
needed,
dose? How many dose? 12 milligrams, 24 hours for how many doses?
2 doses.
Okay. And then you
And
said
then
Dexa.
and then dexamethasone, it's 6 mg intramuscular 4 doses for 12 hours. And then if it's needed, betamethasone
How many?
12.
How many
It's
doses this one?
4 doses. 4
Okay.
doses
And
in 12 hours. And then
okay.
if it felt to be needed, betamethasone 12 mg intramuscular 2 doses in 12 hours can be administered.
Okay. So I would like to tell you now my experience. So I've heard all what you have been doing in practice. So I would like to tell you my experience in my practice. So I have a code. Okay. I have to complete 24 milligrams in 24 hours. So usually during my residency, what we do is Dexa, because betamethasone is not readily available in my country. So Dexa, we give it Q6 hours. So times how many? 4. Okay, Q6 hours times 4 doses. So this is 6 milligrams. 6Q6. So we usually give it 6Q6, 8Q8, 12Q12, or 1 dose in 24. So that's how easy we do it. So 6Q6, 4 doses, 8Q8, 3 doses, 12Q12, 2 doses, and of course 24 milligrams in one shot. Okay, because we know that especially if the patient is in imminent labor, we can give 24 milligrams immediately. So now let's see what the guideline says about the dosing. So we have 2 preparations. Okay, so we have two preparations. We have your dexamethasone phosphate. You give it intramuscular, okay, 12 milligrams in 24 hours apart, or 6 milligrams 12 hours apart. So Dexa, 12 mg Q24 times 2 doses. This for Dexa, or 6 milligrams Q12 times 4 doses. Okay. Alternative is, so the priority is dexamethasone. Okay. Alternative is betamethasone, the same, 12 milligrams, 12, but no 6, no Q6. Okay, beta, if you're using betamethasone, it's 12 milligrams Q24 times 2 doses. Okay, so the preparation available in the UK is betamethasone phosphate, okay? And it should be intramuscular. Oral or transplacental administration is not recommended, okay? So remember, 12 milligrams every 24 hours times 2 doses. So you have to complete 24 milligrams. 24 milligrams in 48 hours, okay? So you have to complete 24 milligrams in 48 hours. So whatever you are using, you have to complete 24 milligram in 24 hours. This is what the guideline says. Okay. So now you know the dosing. So tell me, after giving a course of antenatal corticosteroids, at which time it is most effective?
24 hours to 7 days.
7 days.
Very good.
24 hours.
24
After-
hours from the first dose or from the
The last
second dose?
From the
Very
last
good.
dose.
Very good. So it's 24 hours. You should be able to give the second dose within 24 hours of birth. And it is effective until 7 days before birth. Okay, so let's see what the guideline says. So antenatal corticosteroid reduces neonatal death when the first dose is given within 48 hours, but the second dose should be given 24 hours and 7 days of administration. So what does this mean? So your patient went into labor. So this is your birth, okay? This is 24 hours before birth. This is 48 hours before birth. And this is 7 days. Okay, 7 days. If you were able to give the steroids within this time frame before birth, then it is the highest benefit that you can get in reducing neonatal death. Okay, so remember, the second dose should be given before 24 hours, and the first dose should be given before 48 hours. Okay. So we have mentioned already what are the risks associated with the course with antenatal corticosteroids. So what are those risks that we mentioned a while ago? So you can have what?
Neonatal hypoglycemia.
Okay, if the mother is diabetic and you give a course of antenatal corticosteroid, you can have
What
neonatal
are the risks
hypoglycemia.
associated with this?
What?
High blood.
It's stillbirth.
Stillbirth?
Yes.
So why do we give
Developmental
steroids?
delay.
Developmental delay. Okay, stillbirth, no, huh?
Increase high blood pressure.
Increase high blood pressure to the mother and to the
Transient.
yes,
To the
transient
mother.
high to the mother, yes, and to the baby. The
Low
opposite,
birth weight.
low blood pressure.
Hypoglycemia.
Hypoglycemia has already been mentioned. Okay, so let's see
Low
what the
birth
guideline
weight.
says. Low birth
Transient
weight,
changes.
yes. Yes. So you have here, women should be counseled about the risk and uncertainties. So you mentioned it. If the patient is diabetic, the baby is exposed, will be at risk of neonatal hypoglycemia. It's always the opposite effect to the baby. So if the mother, there's a transient increase in blood pressure, the baby will have low blood pressure. There will be, what else? Developmental delay. Okay, if you give a lot, of course, of corticosteroids. So what are the contraindications to the use of antenatal corticosteroids? What do you think, what situation we can give corticosteroids? What do you think are the conditions that we cannot give antenatal corticosteroids?
Systemic maternal infection.
Sepsis, ma'am.
Very good. Sepsis, systemic infections. Okay, why? Because steroids tend to exaggerate these infections. What else?
Maternal chorionitis.
It's the same spectrum infections. Okay. So do you give steroids to prevent birth in patients with maternal indication for delivery? Do you tokenize the patient in order to wait for the steroid to take effect? I know you're doing this in practice, right? So you tend to tokenize the patient. If she's in preterm labor, you tokenize the patient and give the corticosteroids, and you tokenize the patient in order to delay birth just for the steroid to take effect. No problem, you can do that, but not for those patients with contraindications to tocolysis. For example, the patient comes in placenta accreta, right? So you don't delay the delivery. Even if you were not able to give the steroids, you deliver the baby right away. So the birth should not be delayed in order to administer antenatal corticosteroids when there are serious concern about maternal and fetal conditions. Okay, presence of very good systemic infection. You should know the risk and benefits, because steroids affect exacerbation of symptoms for both the mother and the baby. So if the patient emergency, you need to deliver, you don't need to panic and give the steroids, okay? Because it will never take effect. For example, now you decide this patient is septic, so you cannot give steroids, so deliver the baby. This patient is having abruptio placenta. You know that the steroids will take effect only if you were able to give the last dose within 24 hours. So why would you delay? So deliver. If the patient has antepartum hemorrhage, deliver, okay? So in what circumstances? So you give a course of antenatal corticosteroids, and unfortunately, the patient did not deliver. So are you going to give a second dose?
Yes.
How
Not
many?
recommended now.
How many interval from the last dose if you are going to give?
7 days.
After 7 days.
Okay,
2
so
weeks.
okay, so you mentioned a while ago that steroid is effective 24 hours to 7 days before birth. Okay, if the patient did not deliver with that within that time frame, you can still give. Okay, but there is no additional benefit for it. Only for decreasing neonatal morbidity with regards to neonatal unit admission. Okay, so you see here, there is currently limited evidence to recommend a repeat course of antenatal corticosteroids if a woman remains at imminent risk of preterm birth 7 days after. However, you can give a further course in order to reduce the need for neonatal respiratory support. Okay, so the guideline says that there is no additional benefit, but it can prevent neonatal admission in terms of having neonatal support. Okay, and in case you repeat a course of the steroid, it should not exceed 3 courses. Okay, so the maximum course that you can give is 3. And for the interval, they did not mention, but ideally it should be, of course, 2 weeks after the last dose. So that if I'm not, I don't believe that if you give the first course and the patient did not deliver within 1 week, I'm sure the patient will go into labor in the next week. Okay, so there's no mention in the guideline at what specific interval you should give the next dose, but you can give. If you have to explain to the patient that she can have, because she did not deliver within the 7 days time frame, she can have another course, but you have to explain to the patient that those baby who receive multiple doses of corticosteroids are higher risk of low blood pressure, developmental delay, low birth weight. So you have to have an informed consent. If the patient agrees for another dose, knowing all these risks, then you can give. If the patient did not agree, then there's no harm, okay? So you should have to involve multidisciplinary team all the time. So because you are delivering preterm, you are delivering patients with maternal problems, you have to involve all disciplinary team, okay? Do you have any questions before we summarize? What? Close your microphones. We're about to close. We're about to finish the webinar. Close your microphones. Thank you.
Can I ask you one question, doctor?
Yes, go ahead.
Yes. If suppose a patient is high risk, twin patient, and we have given prophylactic this one corticosteroid around 30 weeks. Okay. And by chance this patient not delivered early. She crosses the 37 weeks.
Good.
And we planned for cesarean for her. So in that scenario, we should give her again the second dose?
At
before
what
taking
time? At what time did you do the cesarean?
After 38 weeks, if I do?
Yes, you have to give. It's the recommendation of the guideline that if you there should be no cesarean section that is before 39 weeks. But if you do plan to have cesarean section at 38 weeks, we have talked about it that these patients are not exposed to the stress of labor. So the guideline says you should give.
Even though she has received one dose previously at 30 weeks.
At 30 weeks. So that's far
No
away.
matter what. Yeah, okay. So
That's
same course.
two months.
Should...
Yes, same course.
Same. Okay. Okay. Thank you.
Okay. Welcome. So
hello, Sam. Hello, ma. Hello, ma.
Yes, dear.
But please, I just want to ask that does it now mean that emergency corticosteroid has a role in obstetrics?
Emergency corticosteroids? What do you mean by emergency corticosteroids?
Like a patient who is going for emergency cesarean section at, let's say, 37 weeks or 38 weeks. And since it is recommended that corticosteroid should be administered before cesarean section, but in that case, the woman is coming in as an emergency case, can we quickly administer corticosteroid?
No, because it will not take effect. Emergency means now. The steroids needs 24 hours, 24 to 48 hours to take effect. Okay, so if this is an emergency, do it. Okay, give antibiotics.
I would say it depends on the type of emergency. Because it's gonna, although the best effect is after 24 hours, if you say you're having a category 3 and you do an emergency in a few hours, it would still have some effect as opposed to not at all. So if it was a premi like 32 weeks and you were going to deliver them later today, I would still give corticosteroids.
Okay, so this is what I'm saying, that you have to separate practice from the exam. Okay, so in our practice, for whatever it's worth, I told you we give 24 milligrams in one dose. Especially,
I don't see that the guideline says don't give it in emergency. If you're having an abruption, obviously you won't give it. You would deliver the baby.
Yes,
I think you have to individualize the case to the emergency, is what I would say, and that's both UK practice and by your guidelines, because I work in the UK.
Yeah, that's true, because when you have to categorize your cesarean section, and you mentioned category 3. When you say category 3, this patient is planned, and then she's, for example, breech, and she suddenly goes into labor. So this patient is not prioritized. So you can still give the steroid. So it's a case-to-case basis. You're right. Okay. Any other questions?
Ma'am, please, I also need clarification concerning the dexamethasone and betamethasone. For the purpose of our exam, we know that what's quoted for in practice is quite different.
Yes, true.
For exam purpose, which one should we follow? I was a bit lost when you mentioned.
Okay,
earlier.
No problem. I'll repeat it here in the summary. Okay. So in summary, any other questions?
Yes, ma'am. I want to ask. That can ACS, like antenatal corticosteroids, can be used in community level care when referral is not feasible?
No problem. You can give antenatal corticosteroids when referral is not possible. But how long does the referral takes place? So if it is within 7 days and then you can refer within 7 days, you can give corticosteroids.
Okay, one last question from me is that can you please make a clarification that do partial doses confer any benefit?
Partial doses? It was not mentioned in the guidelines, but for me, giving one dose is better than giving nothing, right? So when you say partial dose, you were able to give only, for example, 12 milligrams today, and then the patient cannot wait for another dose. Suddenly, she has contractions, she needs to deliver. So I think that one dose has benefit over without giving at all. Correct? Of course, our aim is to complete the dose, but you don't know what will happen, right? That is what the other doctor says. So even if it is an emergency, she still gives a dose of corticosteroids for whatever it's worth.
And doctor, this 24 milligram dose nowhere mentioned in the guideline, right? This is our practice only.
Yes.
Okay.
Because we are afraid. That's like the previous question. So we are afraid that patient will not be able to complete the dose. So we know that the patient will deliver soon. So we give 24 milligrams in one shot. But this is not in the guidelines. Yes, don't confuse yourselves, okay? This is not mentioned in the guidelines. What is mentioned in the guidelines is, I will summarize right now, okay? So who needs corticosteroids? Women in imminent preterm labor. For women undergoing planned cesarean section between 37 and 38 plus 6 weeks, because the NICE guideline says you have to deliver the patient by planned cesarean birth from 39 weeks onwards. From 39 weeks onwards, you don't have to give corticosteroids. Okay, so what do you give? So it's betamethasone, sodium phosphate or acetate 12 milligrams IM, Q 24 hours for 2 doses, or for dexamethasone, there are 2, 6 milligrams IM, Q12 for 4 doses, or 12 milligram IM every 24 hours for 2 doses. So Dexa, we have 2 preparations. So when do you give it? 24 to 34 plus 6 weeks. Okay, and how do you give it? Why do you give it? So it reduces neonatal death when the first dose is given within 48 hours prior to birth, or the second dose, a minimum of 24 hours and a maximum of 7 days completed. Okay, so why do we give it? So you know that a course of antenatal corticosteroids reduces the risk of respiratory distress syndrome, transient tachypnea, and neonatal intensive care unit admission. Okay, do you have any other questions?
Madam, patients who are having antenatal corticosteroids, their neonates have risk of neonatal hypoglycemia. Is that with only GDM or all patients can have it?
All patients.
Okay,
all patients, because your corticosteroids increases maternal sugar levels. Okay, so even if the patient is diabetic or not diabetic, but the risk of neonatal hypoglycemia is higher in patients who are diabetic. Okay. So guys,
one more question, doctor. If suppose the patient is allergic to steroid, then what to do?
So if the patient is allergic, so what do you do?
Cannot give.
Yes. The
in
number
my whole
one
life, one patient I noticed, I encountered, she is allergic to steroid. So that's what I was thinking after that, what to do for her.
Yes, it's a very, very rare situation that a patient is allergic to corticosteroids. But the number one contraindication to all medication is patient allergy. Okay,
yes,
so
correct.
then that's the number one contraindication. So why do you give? You're putting the patient to risk of bronchospasm or whatever. Okay,
Yeah,
so remember, in the UK, it's if the baby is still not born, the priority is given to the mother. The baby inside the womb has no right until the baby is born. So you have to think first of the safety of the mother before thinking of the safety of the baby. If you can think of the safety for both, then it's fine. Okay? Yes?
Ma'am, steroids are given for the treatment of hyperemesis gravidarum also, and the other antiemetics are not effective.
Yes, this is the fourth line for your treatment of hyperemesis. You have to go with your cyclizine first, promethazine, and then the second line, metoclopramide, ondansetron, domperidone, and then the corticosteroids.
And also, ma'am, it is used as a stress dose of steroids during intrapartum period when the patient is already on steroids. This is also another. Yes. Thank you.
Okay, any other questions, guys? So those of you who are my students in part 1, thank you for attending this webinar. Those of you who are part 2 students, thank you for attending this webinar. Those who among you are not yet part of MedExam courses, this is how we conduct our courses in regular group and progressive course. We have a wide range of courses being offered. So if you are interested, just message our team in the chat group and they will respond to you. And I know those who attended this webinar, they will be giving you a special discount, I think for 24 hours if you want to join any of our courses. You just have to contact them in the chat box. Okay? Thank you guys for attending. Happy weekend.
Thank you so much, Dr.
ma'am.
Thank you. Bye-bye.
Thank you, ma'am. Bye.
Thank you.
Thank you, ma'am.